Hi friends, I am Dr. P.K. Hazra from Kolkata. In today's conference, I gave a talk on optimal primary angioplasty. Heart attack is a killing thing. You have many times which you can shorten, like door to balloon time, paper to admission time, heart failure, chest pain. These are killing diseases. The earlier the diagnosis, like if you have a chest pain, calling 911 in US or in our country, calling a physician, doing the ECG or cardiac enzyme, and rushing to the hospital if your symptoms are very suggestive of acute myocardial infarctions. So any gas or any acidity which comes suddenly could be heart attack or STEMI in our terms. The doctor in primary angioplasty center or stroke care or angioplasty care center will do certain tests, will admit you. And once these patients are admitted, they are usually taken to the cath labs and we do angiography and angioplasty. In today's talk, what I told them that doing the culprit artery, culprit plus non-culprit artery by imaging like OCTs, IVUS, laser, cat-RX thrombectomy, good medications, pharmacotherapy like PCSK9, GLP-1, ARNI, and bivaludin, cangrelor. These are the modern pharmacotherapy. If you do not know the background of the patients like their kidney status, their HIV status, hepatitis C status, you can always come back next morning. Always it is a team approach, like you have to have an anesthetist in your cath lab doing primary angioplasty. If you have cardiac arrest or patient needs ventilation, it is always better to keep a second or third hand in your cath lab so that these catastrophes can be avoided. Heart attack patients or large myocardial infarction or stroke patients do not get a second chance in many instances. So time is precious, time is important. So in today's talk, along with other speakers, the chairperson like Dr. Fayashal and Dr. Avi Mehta has highlighted my viewpoint of doing a complete revascularizations. Doing FFR, QFR is of utmost importance. Also, we talked about very sick patients like shock patients who need myocardial like support, MCA support like Impella or intra-aortic balloon pump can be implemented with a large bore device from the groin. If you are really thinking about this mechanical support for very low blood pressure, very sick patients, you can spend 1 hour or half an hour in the patient's groin through which these large catheters are inserted inside the patient's body. These are not without complications, the local complications, bleeding complications. It is a very costly device. This mechanical support is also the state of the art nowadays, also has ventured into the very sick myocardial infarction or stroke patient and can save many lives. Leaky valves now can be treated after myocardial infarction like mitral clip. The myocardial recovery or the muscle recovery is very important. Drugs along with certain pacemakers may be required later in their life. So intracoronary perfusion, microvascular obstruction is two things which go simultaneously. So once you perfuse this artery with your new stent or balloon, drug-eluting balloon, some of the thrombi, smaller thrombi, go into distality and can cause microvascular clogging. Supersaturated oxygen, no flow, reflow, microvascular clogging, I have also talked about. So supersaturated oxygen, a new thing which is FDA approved, is also coming to the help of myocardial recovery. So in summary, friends, in today's talk, myself along with other speakers and chairperson has told the audience, which is mainly the interventional cardiologists, practicing physicians, then many lives can be saved by proper angioplasty, early angioplasty. The DOT to needle balloon time should be as low as possible. Usage of modern device, modern medicines, modern pharmacotherapy, doing angioplasty from the hand, and regular use of a mechanical circulatory support in cardiogenic shock, very sick patients, and a team approach can save many lives. With that, I'd like to thank you for your kind attention.